Staff Sergeant Maya Chen had faced enemy fire in Afghanistan. She'd dragged wounded soldiers from burning vehicles. She'd earned 2 commendations for valor under pressure, but none of that mattered to the doctors at Riverside Military Medical Center in San Diego. To them, she was just another rookie nurse who didn't belong. Maya had left active duty 6 months ago after 12 years of service. The transition from combat medic to civilian nurse should have been smooth. She had more real-world trauma experience than most of the staff combined. But the head surgeon, Dr. Richard Thornton, made it clear from day one that military experience meant nothing in his emergency room. "This is a hospital, not a battlefield," Dr. Thornton had said during her first shift, his voice dripping with condescension. "We do things by the book here, medical school training, not boot camp improvisation." The other doctors followed his lead. They dismissed her suggestions. They rolled their eyes when she spoke up during briefings. When Maya tried to share a technique she'd used to stabilize soldiers in the field, Dr. Thornton cut her off mid-sentence. "We'll stick to proven medical procedures, thank you," he'd said, turning his back to her. The nurses weren't much better. Most had worked at Riverside for years. They'd formed their own tight circle, and Maya was an outsider. During breaks, they'd huddle together, laughing at inside jokes while Maya sat alone with her coffee. When she asked questions about hospital protocols, they'd answer with barely concealed impatience, as if she was wasting their time. Maya kept her head down. She'd dealt with worse than cold shoulders and bruised egos. In the Army, she'd proven herself through action, not words. She figured the same approach would work here. Show up early, stay late, do the work without complaint. Eventually, they'd see her value. But 3 months in, nothing had changed. If anything, the hostility had grown worse. "The ex-soldier thinks she knows better than doctors," she'd overheard one of the senior nurses say in the break room. "She probably doesn't even understand half the equipment we use here." Maya had bitten her tongue and walked away. Getting angry would only prove their point. Besides, she hadn't left the military to fight new battles in a hospital hallway. She'd left because she wanted to save lives without the constant threat of violence. She wanted normalcy, peace, a chance to use her skills without dodging bullets. Her shift supervisor, Patricia Walsh, was the only one who showed her any respect. Patricia had served as a Navy nurse in the Gulf War. She understood what Maya brought to the table. "Give them time," Patricia had told her one evening. "Hospitals are like any other institution. Change makes people nervous. You're different and different scares them." "I'm just trying to do my job," Maya had replied. "I know, and you're doing it well, but they won't see that until something forces them to look." Maya didn't know what that something would be. She just hoped it wouldn't come at someone else's expense. The night everything changed started like any other Tuesday. Maya clocked in at 6 p.m. for the overnight shift. The emergency room was relatively quiet. A few minor injuries. One case of chest pain that turned out to be heartburn. Dr. Thornton was on duty, along with 2 other physicians and a full nursing staff. Around 11 p.m., the emergency radio crackled to life. "Incoming trauma. Male mid-30s gunshot wound to the chest. Navy SEAL training accident at the base. Severe bleeding. ETA 4 minutes." The emergency room exploded into controlled chaos. Nurses prepped the trauma bay. Doctors scrubbed in. Maya took her position at the supply station, ready to hand off whatever the team needed. It was a support role, the kind they always gave her. Never front and center, always in the background. When the ambulance doors burst open, Maya's combat instincts kicked in. She assessed the patient in seconds. The SEAL was barely conscious. His breathing was shallow and rapid. Blood soaked through the pressure bandages the paramedics had applied. His skin had that gray pallor Maya had seen too many times before. This man was dying, and from the look in the paramedics' eyes, everyone knew it. The SEAL's name was Petty Officer First Class Jason Rivera, 28 years old. member of SEAL Team 7. During a live-fire training exercise, a ricochet had caught him in the upper chest, tearing through tissue and nicking his subclavian artery. He'd lost massive amounts of blood before the medics even reached him. Dr. Thornton took command immediately. "Get him on the table. I need 2 large-bore IVs. Type and cross for 6 units. Someone call the OR and tell them we're coming up." The team moved with practiced efficiency. Nurses cut away Rivera's uniform. Another nurse started the IVs while a third attached monitoring equipment. Maya stood ready with supplies, her eyes never leaving the patient. Rivera's blood pressure was dropping, 70/40, then 60/30. His heart rate was climbing, trying to compensate for the blood loss. 130, 140. His body was shutting down. Dr. Thornton worked quickly, examining the wound. "The bullet fragmented. There's shrapnel near the artery. I need to get in there and clamp it off before he bleeds out." But as soon as Thornton began the procedure, Rivera's pressure dropped again, 50/20. The monitors started screaming. "He's crashing," one of the nurses called out. "More fluids," Thornton ordered. "Push 2 units of O-negative. Get me the vascular tray." Maya watched as the doctor worked. She'd seen injuries like this before, dozens of times, in Kandahar, in Helmand Province, in makeshift field hospitals where supplies were limited and time was everything. The standard procedure Thornton was following was textbook correct, but textbook didn't always work when someone was bleeding out this fast. "Pressure's still dropping," the monitoring nurse announced. 40/0. Dr. Thornton's jaw clenched. Sweat beaded on his forehead despite the cool temperature of the trauma bay. "I can't get a clear view. There's too much blood. Suction, more suction." Another doctor stepped in to help, then a third. They worked in synchronized movements trying to find and repair the bleeding vessel, but Rivera's blood pressure kept falling. His skin grew paler. His breathing became more labored. "We're losing him," someone said. Maya's hands gripped the supply cart. Every instinct screamed at her to step forward, to speak up, but she remembered the last time she tried to offer a suggestion. The dismissal, the condescension, the clear message that her input wasn't wanted. "Start chest compressions," Dr. Thornton ordered. "Continue ventilation, push epi." A nurse began compressions. The room fell into the grim rhythm of a code. Compress, breathe, monitor, drug, compress, breathe, monitor, drug. 5 minutes passed, then 10. Rivera's heart would start, then stop again. The doctors tried everything in their arsenal. Different medications, direct pressure, additional units of blood. Nothing worked. The bleeding was too severe, too deep, too complicated. "Maybe we should crack his chest," one of the younger doctors suggested. "Too risky in his condition," Thornton replied. "We need to stabilize him first." But they couldn't stabilize him. That was the problem. Every intervention failed. Every procedure fell short. Maya counted 19 different medical professionals who cycled through that trauma bay in 20 minutes. Doctors, nurses, specialists called in from other departments. Everyone had an idea. Everyone tried something. Nothing worked. Patricia Walsh caught Maya's eye from across the room. The older nurse's expression was grave. She'd seen enough deaths to recognize when someone was beyond saving. Her slight shake of the head confirmed what Maya already knew. Jason Rivera was going to die. "Blood pressure undetectable," the monitoring nurse said quietly. Dr. Thornton stepped back from the table, his gloves covered in blood. The other doctors did the same. The resignation on their faces was unmistakable. "Time of death," Thornton began. "Wait," Maya said. Her voice was quiet but firm. Every head in the room turned toward her. Dr. Thornton's eyes narrowed. "Excuse me." Maya stepped forward. Her heart pounded, but her hands were steady. She'd made her decision. "I know a technique, something I used in Afghanistan. It might work." "This isn't the time for battlefield experiments," Thornton snapped. This man needs proper medical intervention, not. He's dead, Maya interrupted. You just said it yourself, so what's the harm in trying? The room went silent. Several nurses looked away. One of the younger doctors shifted uncomfortably. Dr. Thornton's face flushed red. How dare you? 30 seconds, Maya said, meeting his glare without flinching. Give me 30 seconds. If it doesn't work, you can call it, but if there's even a chance. She let the sentence hang. Everyone in that room knew what she was saying. Everyone knew that conventional methods had failed. They'd tried everything by the book, and Jason Rivera was still dying on their table. Patricia spoke up. Let her try, Richard. Dr. Thornton looked like he wanted to argue. But then his eyes went to Rivera's ashen face, to the flat line on the monitor, to the 19 medical professionals who'd failed to save this young SEAL's life. 30 seconds, he said through gritted teeth. And when this doesn't work, you're done at this hospital. Maya nodded. She'd expected nothing less. Maya moved to Rivera's side with the confidence of someone who'd done this before. Not once or twice, but dozens of times under conditions far worse than a well-equipped trauma bay. She'd performed this procedure in sandstorms, under mortar fire, with limited supplies and no backup. If it worked here, it would work anywhere. I need everyone to step back, she said. Give me room to work. Dr. Thornton crossed his arms but didn't interfere. The other medical staff created a half-circle around the table, watching with a mixture of skepticism and curiosity. Some probably hoped she'd fail. Others just wanted to see what this rookie nurse thought she could do that 20 doctors couldn't. Maya took a deep breath and centered herself. The technique she was about to use wasn't taught in nursing schools. It wasn't in any American medical textbook. She'd learned it from a British SAS medic during a joint operation in Helmand Province. He'd learned it from an Israeli combat physician. It had been passed down through generations of military medical personnel who worked in situations where traditional methods weren't enough. The technique had a simple name: resuscitative endovascular balloon occlusion of the aorta, REBOA for short, but the military version was different from the hospital version. Faster, more direct, designed for combat conditions where every second counted. I need a Foley catheter size 14, Maya said, and a 50cc syringe. One of the nurses handed her the supplies without question. Patricia added a few additional items to the tray, anticipating what Maya might need. Maya worked quickly but carefully. She inserted the catheter through the femoral artery in Rivera's groin, advancing it upward toward his chest. The principle was simple: create a temporary blockage above the injury site to redirect blood flow to vital organs while controlling the hemorrhage. In a hospital setting, this procedure required specialized equipment and imaging to guide the catheter. But Maya had done it by feel in the back of a helicopter in the dark, with a wounded soldier screaming in her ear. She knew the anatomy. She knew the landmarks. Her fingers found the path as naturally as breathing. What is she doing? One of the doctors whispered. Modified REBOA, Patricia replied. I've heard about it, never seen it done this way. Maya ignored them. She focused entirely on Rivera's body, on the subtle feedback from the catheter, on the tiny signs that told her where she was and what she needed to do. She advanced the catheter carefully, feeling for the right position. When she reached the descending aorta, just above the injury site, she stopped, inflating the balloon now. She attached the syringe and slowly injected saline, inflating the small balloon at the catheter's tip. The balloon expanded, creating a temporary dam inside Rivera's aorta. Blood flow to the lower body decreased, but flow to his heart and brain increased dramatically. For 5 seconds, nothing happened. Then the monitor beeped, once, twice. A rhythm started to appear on the screen. I've got a pulse, the monitoring nurse said, her voice filled with disbelief. Weak, but it's there. Blood pressure rising, another nurse added. 60/40, 65/45. Dr. Thornton stepped closer, his expression shifting from skepticism to amazement. How is this possible? Maya didn't answer. She was already moving to the next step. I've bought us time, but not much. Maybe 10 minutes. You need to get him to the OR now and repair that artery. The balloon won't hold forever. The room erupted into controlled chaos again, but this time it was purposeful, hopeful. The staff mobilized to move Rivera to the operating room. Equipment was gathered. The surgical team was alerted. Within 90 seconds, they were wheeling him toward the elevator. Dr. Thornton paused before following. He looked at Maya, and for the first time since she'd started working at Riverside, there was something other than contempt in his eyes. Not quite respect. Not yet, but acknowledgement. "Where did you learn that?" he asked. "Afghanistan," Maya replied simply. "We couldn't always wait for the perfect conditions. We had to improvise." He nodded slowly, then turned and followed his patient to surgery. The trauma bay emptied quickly. Soon only Maya and Patricia remained, standing amid the blood-stained gauze and discarded equipment. "That was remarkable," Patricia said softly. "I've worked in emergency medicine for 30 years, and I've never seen anything like that." Maya's hands started to shake now that the adrenaline was wearing off. She'd gambled everything on that technique. If it had failed, she would have been blamed for Rivera's death. Dr. Thornton had made that clear. Her career would have been over before it really began. "I wasn't sure it would work," Maya admitted. "Hospital conditions are different from combat zones, but I had to try." "You saved that young man's life," Patricia said firmly. 20 doctors couldn't do what you just did. Don't ever forget that." Maya cleaned up mechanically, her mind replaying the procedure. Had she done everything right? Had she positioned the balloon correctly? Would Rivera survive the surgery? 2 hours later, word came down from the operating room. Dr. Thornton had successfully repaired the damaged artery. Rivera was stable, critical but stable. He was going to live. Maya sat in the break room when she heard the news. She put her head in her hands and let out a breath she felt like she'd been holding since the moment Rivera arrived. She'd done it. Against all odds, against all doubts, she'd saved him. Part 4, the truth comes out. The next morning, Maya arrived at the hospital expecting the usual cold reception. Instead, she found something different. The emergency room staff watched her with new eyes, curious, assessing. The open hostility was gone, replaced by something more complicated. Dr. Thornton called her into his office before her shift began. Maya prepared herself for another lecture. Instead, she found him sitting at his desk, looking tired and contemplative. "Petty Officer Rivera is awake," he said without preamble. "He's asking to see you." Maya blinked in surprise. "Me?" "Apparently, someone told him you saved his life." Thornton leaned back in his chair. "I need to understand what happened last night. That technique you used, REBOA, we have the equipment to perform that procedure here. Why didn't any of us think of it?" Maya chose her words carefully. "The hospital version requires imaging guidance and specialized training. It's not typically used in emergency situations because of the setup time. The military version is different, faster. We use anatomical landmarks instead of imaging, but it's also riskier." "How many times have you performed it?" 37 times in combat situations. 31 of those patients survived long enough to reach surgical care. Thornton's eyebrows rose. "That's an 84% success rate under battlefield conditions. That's remarkable." "It's necessary," Maya corrected. "When you're under fire and the nearest hospital is an hour away by helicopter, you do what works." Thornton was quiet for a long moment. Then he said something Maya never expected to hear from him. "I was wrong about you." Maya said nothing, waiting for him to continue. "When you arrived here, I saw a former soldier trying to play nurse. I thought your combat experience would make you reckless, aggressive. I worried you'd treat patients like casualties instead of people." He met her eyes. "I was wrong. Your experience didn't make you reckless. It made you capable in ways the rest of us aren't." "I'm still learning hospital protocols," Maya said. "There's a lot I don't know about civilian medicine. And there's a lot we don't know about trauma care under extreme conditions," Thornton replied. "Maybe we could learn from each other." It wasn't quite an apology, but it was close. Maya nodded. "I'd like that." When she visited Rivera in the ICU, she found a young man who looked nothing like the dying SEAL from the night before. He was pale and weak, connected to various monitors and IV lines, but his eyes were alert, and his smile was genuine. "They told me you're the one who saved my life," he said, his voice raspy from the breathing tube that had been removed that morning. "I just bought you some time," Maya replied. "The surgeons did the real work." "That's not what Dr. Thornton said. He told me everyone thought I was gone. Then you stepped in and did something nobody else thought of." Rivera studied her face. "You were military, weren't you? I can always tell." "Army, combat medic, 12 years. "Thank you," he said simply. "Not just for saving my life, but for not giving up when everyone else did." Maya felt emotion tighten her throat. This was why she'd become a medic in the first place. Why she'd endured the deployments, the danger, the trauma. For moments like this. For the knowledge that her skills, her training, her experience had made a difference. Over the next few days, word of what happened spread through the hospital. The story grew with each telling. Some versions were accurate, others were embellished. But the core truth remained. A rookie nurse had saved a dying SEAL using a technique she'd learned in combat. The other nurses started treating Maya differently. They invited her to lunch. They asked about her military service. They wanted to know about the technique she'd used, about what else she'd learned in Afghanistan. The doctors were slower to warm up, but even they began to show respect. During patient briefings, they listened when Maya spoke. They asked for her input on trauma cases. They acknowledged that her experience brought value to the team. But not everyone was pleased with Maya's sudden recognition. Dr. Alina Bradford had worked at Riverside for 15 years. She was chief of emergency medicine, technically Dr. Thornton's superior, and she'd been on vacation when Rivera was brought in. When she returned and heard about the incident, her reaction was immediate and hostile. "This is completely unacceptable," Bradford said during a staff meeting 1 week after Rivera's rescue. Her voice was cold and clipped. "A nurse performed an advanced interventional procedure without physician supervision, without proper imaging, without following protocol." Maya sat in the back of the conference room, feeling the mood shift. The warmth that had been building over the past week evaporated instantly. Dr. Bradford stood at the front of the conference room, her expression severe. Behind her, a PowerPoint presentation displayed hospital protocols and procedures. To Maya, it felt less like a staff meeting and more like a trial. "Let me be clear about what happened," Bradford continued, clicking to the next slide. "A nurse with 3 months of hospital experience decided she knew better than 20 medical professionals. She performed a high-risk procedure without authorization, without imaging guidance, and without following established protocols. The fact that the patient survived doesn't change the fundamental recklessness of her actions." Maya felt eyes turning toward her, some sympathetic, others uncertain. She kept her expression neutral, but inside her stomach churned. She'd faced down enemy combatants with less anxiety than this. Dr. Thornton raised his hand. "Alina, I was there. I authorized her to attempt the procedure. The patient was clinically dead. We had nothing to lose." "You authorized her in a moment of desperation," Bradford shot back. "That doesn't make it sound medical practice. What if she'd perforated the aorta? What if she'd caused a stroke? We would be looking at a massive lawsuit right now." Patricia Walsh spoke up from her seat. "But she didn't. She saved a man's life." "This time," Bradford emphasized. But what about next time? Are we going to let nurses override physician decisions whenever they feel like it? Where does it end? The room fell silent. Maya realized that this wasn't really about protocols or procedures. This was about power, about hierarchy, about a doctor who felt threatened by a nurse who'd succeeded where physicians had failed. Maya stood up, every head turned toward her. "May I speak?" she asked. Bradford's jaw tightened. "This isn't a discussion, Nurse Chen." "With respect, Dr. Bradford, it should be." Maya's voice was calm but firm. "You're talking about disciplining me for saving a patient's life. I think I have the right to explain my actions." Thornton nodded. "Let her speak, Alina." Bradford gestured impatiently. "Fine, explain yourself." Maya walked to the front of the room. She'd briefed generals in combat zones. She could handle one hostile administrator. "You're right about one thing," Maya began. "I didn't follow standard hospital protocol, but I did follow the protocol I was trained on: battlefield trauma care. In combat medicine, we have a saying: do what works, not what's convenient, not what's in the textbook, what actually saves lives." She clicked to the next slide, changing Bradford's presentation to a medical journal article she'd queued up that morning. This is from the Journal of Trauma and Acute Care Surgery, published last year. It's a study on REBOA procedures in pre-hospital settings. The conclusion: when performed by trained personnel, field REBOA has comparable success rates to hospital-guided procedures, with significantly faster deployment times. She clicked again. Another article appeared. This is from the British Medical Journal, a meta-analysis of combat casualty care. The findings show that techniques developed by military medics often outperform civilian protocols in severe trauma cases because they're designed for the worst possible conditions. Maya turned to face Bradford directly. "I have performed this exact procedure 37 times under combat conditions. My success rate is 84%. The national average for in-hospital REBOA is 72%. I didn't act recklessly. I acted based on extensive training and experience." "Combat medicine is not the same as hospital medicine," Bradford insisted. "You're absolutely right," Maya agreed. "In combat, I had worse equipment, worse conditions, and less support. If I could save lives there, why would I be less capable in a fully equipped trauma bay?" One of the younger doctors raised his hand. "Dr. Bradford, I've been reading about military trauma care since the Rivera case. Nurse Chen is correct. Many of the techniques now standard in civilian emergency medicine originated in combat zones. Tourniquet use, tranexamic acid for hemorrhage, damage control surgery, all military innovations." Another doctor added, "I looked at Rivera's case file. He had a 98% mortality probability based on his injuries and vital signs. Conventional interventions had failed. Nurse Chen's technique was our last option." Bradford's expression hardened. "This isn't about whether it worked. It's about maintaining proper authority and chain of command in this hospital." "No," Patricia Walsh said, standing up. "This is about ego. Maya succeeded where we failed, and you can't accept that a nurse with combat experience might know something our doctors don't." The room erupted in murmurs. Bradford's face flushed red. "That's out of line, Patricia." "Is it?" Patricia challenged. "Because from where I'm sitting, you're trying to punish someone for saving a life. What message does that send to our staff? That we value hierarchy over outcomes? That we'd rather let patients die than admit we don't know everything?" Dr. Thornton stood as well. "I've been thinking a lot about this over the past week. Our emergency medicine protocols are excellent for typical cases, but severe combat-type trauma, we're not as prepared as we should be. Nurse Chen's background is an asset we should be leveraging, not punishing." "I agree," said another doctor, then another. Soon, half the room was nodding in agreement. Bradford looked around, realizing she was losing control of the room. "This is inappropriate. We have policies for a reason." The conference room door opened. A man in a Navy dress uniform entered, a captain, based on his insignia. Behind him was Jason Rivera, still moving slowly but steady on his feet. "Excuse the interruption," the captain said. "I'm Captain Michael Rhodes, commanding officer of SEAL Team 7. I heard there was a meeting about the medical care provided to one of my men. I thought I should attend." Bradford straightened. "Captain, this is an internal hospital matter." "With respect, doctor, when one of my SEALs nearly dies and then is saved by exceptional medical care, it becomes a Navy matter too." Rhodes looked at Maya. "Is this the nurse who saved Petty Officer Rivera's life?" "Yes, sir," Maya replied. Rhodes walked over and extended his hand. "Thank you, Staff Sergeant Chen. I read your service record, 12 years as a combat medic, 2 Bronze Stars, multiple commendations. The Navy owes you a debt of gratitude." He turned to address the room. "I've also been briefed on the technique you used. The Navy's Medical Command is very interested in training our corpsmen on field REBOA procedures. We'd like to invite Nurse Chen to help develop that training program." Bradford tried to interject. "Captain, as I said, this is an internal." "I'm not finished," Rhodes said, his voice taking on a command tone that silenced the room. "I've also spoken with the hospital administrator and the board of directors. They were very interested to learn that one of their nurses saved a Navy SEAL's life using advanced combat trauma techniques. In fact, they're considering creating a new position, Director of Combat Trauma Integration, someone to help bridge the gap between military and civilian emergency medicine." He looked at Maya. "They asked if I knew anyone qualified for such a position. I gave them your name." The room went completely silent. Maya felt her heart racing. A director position. That would put her on equal administrative footing with the physicians. It would give her the authority to implement changes, to teach, to make a real difference. Bradford found her voice. "This is highly irregular. Nurse Chen has only been with us for 3 months. And in those 3 months, she's already demonstrated more practical trauma expertise than most of your staff will develop in a career," Rhodes replied. "The question isn't whether she's qualified. The question is whether this hospital is willing to evolve." Dr. Thornton spoke up. "I think we are. I vote yes on the new position and yes on Nurse Chen as the ideal candidate." "Seconded," Patricia said immediately. Other voices joined in, agreed, yes, she's earned it. Even some of the doctors who'd been skeptical initially nodded their support. The tide had turned completely. Bradford stood alone in her opposition, and she knew it. "I'll need to review this with the board," she said stiffly. "Of course," Rhodes replied. "They're expecting your call." 3 months later, Maya stood in front of a classroom filled with Navy corpsmen, Army medics, and civilian emergency room staff. As the newly appointed Director of Combat Trauma Integration, she developed a comprehensive training program that combined military field techniques with hospital resources. On the wall behind her was a photo of Jason Rivera, fully recovered and back with his SEAL team. Next to it were photos of 6 other patients who'd been saved using techniques Maya had introduced to the hospital. Dr. Thornton sat in the front row, taking notes like any other student. He'd become one of Maya's strongest advocates, often telling people that watching her work had made him a better physician. Even Dr. Bradford had come around eventually. She'd never apologized, but she'd stopped obstructing and started listening. Sometimes that was enough. As Maya began her lecture, she thought about how far she'd come. From being dismissed and underestimated to leading innovation in trauma care. From being told her experience didn't matter to proving it was invaluable. She'd faced down enemy fire in Afghanistan, but standing up in that conference room, fighting for her value and her principles, that had taken a different kind of courage. "Today we're going to talk about field expedient hemorrhage control," Maya announced to her class. These techniques were developed in combat zones, but they can save lives anywhere. The key is knowing when traditional methods aren't enough and having the courage to try something different. A young corpsman raised his hand. What if people say you're being reckless, that you're not following protocol? Maya smiled, thinking of Dr. Bradford's accusations, of all the doubters who'd underestimated her.